Hello, everyone. Welcome. For those of you who have been here before, welcome back. Those of you who are new, welcome to the 90-Day Crisis Jam and the first one of 2024. My name is Dr. Chris Drapeau. I'm Director of Research and Evaluation for the Administrator of the 90-Day Suicide and Crisis Lifeline, Vibrant Emotional Health. I'm pleased and honored to be your host for today's episode number 156. We have a little bit of a different format today. It's our pleasure to really take some time to have a fireside chat with a remarkable individual who's not only reshaped our understanding of stress and mental health, but also could introduce a paradigm shift in terms of how we think about suicide prevention and crisis response. But before we introduce our Professor Sapolsky, I'm curious if we could go to our quote for the day, focused on cross-pollination, which is really meant to set the stage for this fireside chat. And so the main idea of this is that sometimes to find those new innovative ways of thinking about how to solve a complex problem, you need to look at other disciplines and ideas that may not seem to be related on the surface, but actually could be quite transformational once you explore them further. So without further ado, I'd like to introduce Dr. Sapolsky, who is currently the John A. and Cynthia Fry Gunn Professor at Stanford University. As mentioned, he has been focused on studying stress and has spent decades studying the intricacies of stress and its impact on the brain and behavior. His work has also seamlessly integrated a number of academic areas: neuroscience, neurobiology, primatology, and psychology, just to name a few. So really positions Dr. Sapolsky as a torchbearer of sorts in terms of how to do this interdisciplinary work and a beacon for those of us who are committed to unraveling the complexities of human behavior. In the context of suicide prevention in particular, I would argue that Dr. Sapolsky's insights can and are indispensable. His work challenges us to transcend and look beyond the disciplinary silos and collaborate across diverse domains, recognizing that the multifaceted nature of human experience demands an equally multifaceted approach to intervention. So Dr. Sapolsky, we had the chance to meet back in April of 2019 at the 52nd Annual Conference of the American Association of Suicidology. And I had the opportunity to chair that conference with David Covington, who was then the president-elect of AAS. And I was reading your book, Behave, at the time and said, we really should take a look at this as centering the theme of this conference, which we ended up talking about the idea of convergence. And the theme we eventually landed on was converging fields, expanding perspectives. And really the idea of this was born from your work, and specifically this book, Behave, that will be the feature of our fireside chat today. So let's transition into the first question here. You noted early on in the book, Behave, that the most important idea in the book is the following: when you explain a behavior via specific academic discipline, you are implicitly invoking all of the disciplines. Any given type of explanation is the end product of the influences that preceded it. And then you built on this by mentioning that attributing behavior to a single factor, be it a specific gene, hormone, or even a childhood trauma, can oversimplify the intricate web of influences. So in the United States, as you may be aware, we're facing some complex challenges with the number of suicides and overdoses reaching near record highs for sure in terms of sheer number. And so this really creates a dilemma for us researchers who've been studying these things for years, even decades. And I'm curious what advice you would have for those of us who are wondering how we can do this better. How can researchers improve their approach to encompassing all relevant disciplines and influences when studying complex human behaviors like suicide?
Well, first off, thanks for the very nice introduction. I say as I flail for a moment here, trying to come up with something that will sound useful. I think what we see is, basic theme: take interdisciplinary approaches, take multidisciplinary approaches. Any single one is going to trap you with certain limitations, certain assumptions, and so on. But if you're going to be somebody finding out new facts about the universe, you got to spend more and more time on less and less, on some tiny little sliver of hopefully what turns out to be reality. And it's very comforting then to just stay within that sliver, because my God, you've given up so many evenings where you could have been relaxing, instead thinking about this minutia or whatever. One gets an understandable emotional sort of attachment to one's own disciplinary approach. So it takes some work to push outside it. So don't be horrified if you would much rather just stick with what you know already.
So do you have any recommendations of maybe tactics that we could employ as researchers? I think we're all aware that there are cognitive biases that influence which directions we go and could also influence the reproducibility of the research we do. But have you learned throughout your career how to keep your perspective expanded when you are tempted to really narrow it and stick with a certain line of reasoning?
Well, I've always had sort of this luxury of having had this dual career. I'm like half of a neurobiologist in a lab and neurons and sticking genes into them, and half a primatologist where I spent more than 30 summers studying a population of baboons, wild baboons in a national park in East Africa. And I would find the right rhythm was just when you were feeling completely burned out with like the lab is impossible and yet another grad student having a nervous breakdown because the rats aren't doing what they're supposed to do. And you get to go sit in a tent and think about instead issues of behavioral ecology and evolution, and totally refreshing. And just as you sit there and realize, oh my God, I'm not going to get anywhere with this. This is going to take me decades to figure out what they're, you get to go back to the lab. And I just found, in a very literal sense, I had the fortune of being able to jump back and forth between two very different worlds of thinking. That was easy for me in the sense of, you're either sitting there in a tent or you're sitting there in your office trying to figure out your NIH budget. So I had the luxury of it being very palpable, very tangible. But I think for anyone finding ways of, stimulating how to turn your despair and burnout with one approach into enthusiasm for trying a different approach is what will sustain you.
So it's keeping up the curiosity as you're continuing to explore seems to be essential to making sure you don't become too narrow in your thinking.
With any luck, yes.
Well, excellent. And Dr. Sapolsky, we have quite an array of folks who typically attend these crisis jams. So not only do you have researchers here, but you have policymakers, you have state government leaders, even crisis responders themselves. And I think there's a theme in your book I think is really important for this audience to hear you talk about. You discuss in depth the human tendency to categorize other people, in their outgroups or us versus them categories. And it's particularly when engaging in moral decision making, which you could argue might be at play when responding to someone in an acute mental health crisis. So I'm curious, how can the understanding of these automatic us versus them distinctions be practically applied, perhaps training crisis hotline workers or mobile crisis responders when they're reaching out and trying to support people in acute states?
Well, in terms of thinking about, sort of a whole approach about us theming, and I think we've got no shortage of seeing just how blood-soaked the world could be over us-them dichotomies. I think the thing to keep in mind is you're dealing with what are two simultaneous contradictory truths. The first one being our brains are incredibly wired for breaking the world into us's and them's. We do it in a fraction of a second, automatically, implicit biases that we're not even aware of. It's demonstrable in infants by 10 months of age or so. They show some reliable distinctions between us's and them's, and to increase their blood pressure a whole lot more to the them's and the us's. We're not the only species that does it. There's, hardcore neurobiology of it. Oh my God, we are hardwired to divide the world into us's and them's and not like the them's a whole lot. And meanwhile, there's this other truth that because of the bizarrity of us as a species, it's incredibly easy to manipulate us as to who counts as an us and who counts as a them. And sometimes this could be for the worse when you've got some, ideologue who's going on about how the thems are vermin, are infestations, or cancers, or whatever. And what you're invoking is sort of the psychology of pseudo speciation, making thems seem so different that in effect, it hardly even matters when you kill them or when you discount their needs or whatever. And on the other hand, the whole world of pseudo kinship, all the ways in which we can feel relatedness to people in a deeply empathic, potentially even self-sacrificing way, in a fraction of an instant, a them can become an us. And that's some room for optimism there.
I really appreciate what you share there, Dr. Sapolsky, because it sounds like the language we use when describing others matters, the adjectives that are used. What would you say about that when people are thinking about how to label different groups of people in terms of how it can influence how they feel and how they approach?
Well, just to get all neurosciency here, I've long been fascinated by the fact that our brains are very elegant and they can do math and remember sonnets and whatever. But there's a domain in which there's a very awkward bit of vulnerability, which is how our brains handle metaphors. Which is we have a whole lot of trouble confusing metaphors with the real things. Let me give an example. There's this part of the brain called the insular cortex, and you find it in every mammal out there, and all of them, including us. It does something very basic. You take a lab rat, you take a monkey, you take a college freshman, whatever, and you let them bite into some totally disgusting, rancid piece of food. And within a fraction of a second, the insular cortex activates. It triggers all sorts of reflexes to spit out whatever the food is. Your stomach heaves, you come close to throwing up, your face scrunches up, all of that. And what's the insular cortex about? It's for detecting and acting upon gustatory disgust, olfactory disgust. And this is a very good thing because, we need to have mechanisms so we don't consume toxic stuff too easily. Great, it's evolved for that. Now take somebody, put them in a brain scanner where you've just had them eat something disgusting and you see the insular cortex activates. Do something more subtle. Show them a picture of somebody eating a tarantula or God knows what. And the insular cortex will also activate. Oh, we don't actually have to have that sensory experience. We could just imagine it and whoa, we've got fancy brains. Now you do something even more interesting. Put that person in the scanner. Don't give them something disgusting to eat. Don't make them think about something. Make them think about somebody's moral disgust. Make them think about some action that is sickening. Make them think about someone who's just done something appallingly brutal to somebody else. And the insular cortex activates. And what's going on? You have a bad taste in your mouth from what that person just did. It makes you feel sick to your stomach. My God, I feel queasy when I read about what's happening over in that part of the world. The insular cortex has neurons that can't tell the difference between sensory disgust and moral disgust. And this can be a very good thing because sometimes it takes like viscera in your stomach lurching to get sort of the moral head of steam to go and do something about something awful like that. But some of the time it's incredibly dangerous because what you're wound up with is this weird kind of litmus test. How do I tell what I think of thems? Well, if they eat differently enough from how I do, if they look differently, if they pray differently, if they love differently, whatever, and my stomach lurches, ah, that's how you know that they are disgusting and so different that it's simply wrong when they go about doing themselves. And there's a whole sort of reflexology of incredibly rapid moral decision making built around disgust, and it almost always sends you in a bad direction. And it's all due to the fact that, organisms have been eating disgusting things for, I don't know, 100 million years. And we've only had the concept of moral disgust for 10, 20,000 years or so. And you can't get a new part of the brain that quickly. So there was presumably some sort of committee meeting where they said, oh, insular cortex, it does disgusting tastes. Maybe it should do this disgusting moral thing we're just sort of working out here. Good. Give me some duct tape. Let's shoehorn it in there. And suddenly moral disgust is in the sort of portfolio of the insular cortex. And thus we have trouble telling the difference between metaphor and the real thing. And that could be for better or it could be for worse.
Yeah, I think this is an excellent point that it's another example of why spanning academic disciplines is important, because how do you incorporate this knowledge into how we work with people in an acute mental health crisis, knowing that there are things going on biologically we may not be aware of. So here's something I wanted to pose to you, Dr. Sapolsky, because crisis interventions are sometimes carried out, whether it's on a crisis hotline, via phone, chat, text, a mobile crisis team responding in person. There are high stakes situations that come up that could have life or death implications. So in these situations, split second decisions are necessary, but also it would be important that we know the nuances of what's going on in this person's life to know how to support them in those moments. But there's complexities and risks inherent in these situations. So I'm curious if you have any advice for any kind of frontline responders, crisis interventionists, to strike a balance between the need for swift intervention, but also the necessity to employ cognitive strategies that you advocated for in your book, Behave. Some examples might be slowing down our response to our immediate intuitions, taking the perspective of the other person who's in crisis, and then managing empathic states. And I'm curious if there are specific training approaches you might recommend to try to cultivate that delicate equilibrium between those two states.
Well, all that said, I emphasize I'm not a clinician. My universe consists of rats and baboons and neurons growing in petri dishes. So, like, I know nothing about the real world. But I find very useful sort of a dichotomy, a view that has come out of the work of the psychologist at Harvard, Josh Green, amazing scientist, where he thinks a lot about us and them and how the brain responds to it. And what he notes is you get somebody in a circumstance where they have to make a rapid moral decision. And is it going to be a pro-social one? Is it going to be one that is helping out somebody else? Or is it going to be basically a selfish one? And what he finds is if the person you were thinking about whether or not to help, if they count as an us, the faster you force a response out of the person, the more pro-social it's going to be, the more altruistic, the more cooperative, the more an us evokes an immediate response of connectedness and pro-sociality. And it's when you have more time to think about it, that's when you come up with, it's not really my problem, or somebody else is going to take care of it, or, they really brought it on themselves, or maybe they're really not as much of an us as I thought they were. When you have more time to think about it, you come up with reasons why to turn the page. In contrast, if it's the problems of the them that you're reacting to, what he shows is the faster you have to react, the more antisocial the responses are going to be, to look the other way, to decide it's not my problem, to decide, look, that's what they're like. They've always been that way. They're always going to be that way. This is just another one of them's. And the more time you have to think about it, the greater the likelihood to get the emotional distance to say, wait a second, is this really a logical response on my part? Am I overgeneralizing? Am I being incredibly distortive and prejudiced? What's the world look like from this person's perspective? I know nothing about their world. The more time you have to think about it, the more you could come away from the worst of your reflexes when it's about a them. When it's an us, your fastest reflexes are pro-social. And I think that's an incredibly important dichotomy to make there.
And I wonder, Dr. Sapolsky, is there a way for those in the crisis response suicide prevention field? Is there a way to make it more likely that we'll see those we're helping as an us? Because there are some important quotes I pulled out related to what you discussed right here. And you noted in the book that if feeling someone else's pain makes us feel awful, the lack of I guess the likelihood of a pro-social action is reduced. And in addition to that, empathic states are most likely to produce compassionate acts when we manage a detached distance. And so I'm just curious if, is there anything you would add to that? Because I know context always matters in these discussions, but it seems like if we are distressed by another person's pain, that may not actually help us help them in that moment.
Well, this is getting sort of the next step after whether or not you're going to feel empathy for this person and Here's the ways in which it's more likely if it's a them. Here's the ways if it's an us. But hooray, you're feeling empathy for them. And the gigantic danger at that point is that empathy will seem like a virtue in and of itself. And that's kind of a trap these days because empathy is such an empathic term to trot out in every possible circumstance. And let's all be empathic. And all of that ignores the fact that this isn't accomplishing anything if you don't turn that empathy into action, into compassion, rather than just deciding, well, that's great. I feel empathy. Wow, what a empathic person I am. If your response is one that actually leads you to acting and acting upon it, and acting upon it often involves doing the harder thing, doing the more threatening thing, doing the more scary thing, so on, of being able to actually act on it. Everybody stands around being incredibly distressed that the kid has fallen into the icy river, and who's the one person who suddenly jumps into the water and goes saves the kid? That transition from empathy to compassion. And what you allude to is the fact that pain is painful. We want to avoid pain, and that includes the circumstances where we are feeling somebody else's pain. And just to get back to that metaphor stuff, there's another part of your brain. It's called the anterior cingulate. And there's neurons there that could not tell the difference between whether your finger is being poked with a pin or you're watching it being done to your loved one. Their pain is your pain and all that. So empathic pain can be painful as hell. And what we often find is it becomes way too much. And what we do is we flee from it. We figure out why it's not my problem. We figure out why it's not really that bad for them, whatever. We look the other way because it has become too painful to actually act on it. And what we do is we flee instead. And two levels, sort of two disciplinary approaches for trying to see when that works to your benefit and works not. One is a more cognitive one. If what you're sitting there and doing is saying, oh my God, it would feel so awful if this were happening to me, you're going to flee from it. It's going to become too painful. If instead you're sitting there saying, oh my God, this must feel so awful for them, let me try to imagine that, that puts you in the position where you're much likely to act compassionately rather than fleeing. And as a physiologist, I'm like totally pleased by how this maps out on another level. Sit somebody down and tell them about something totally appalling happening to somebody else. And if their blood pressure goes up and their heart rate increases and they start secreting stress hormones, that's someone who is going to feel the pain so sharply and acutely that they've got to flee from it. That's a sign that their body is just responding in a way where all they want to do is look for a way to stop their own empathic pain. You get somebody who instead has a more detached response to it, and they do what anybody in a helping profession sort of has to learn, which is some points you're doing something painful to somebody to help them. And like you're a pediatrician and you got to vaccinate a child and you've got to harden in those ways, the training that goes into all these cases. I saw a wonderful example of this years ago. Dalai Lama is very into neuroscience, which is totally cool. And he holds these seminars where he gets sort of his all-star meditative Buddhist and stuff when they hang out with neuroscientists for a few days. So I got invited to one of these, and it was like totally cool hanging out with these people. And we, of course, were spending half the time figuring out that we were using totally non-overlapping vocabularies. And as we all got more comfortable with each other, a bunch of us neuroscientists sort of said to this one kind of approachable guy, saying, so, like, is there ever a time when you're meditating, you've just been meditating for God knows how many hours, and you just stop because your knees hurt like crazy? And the guy said, well, I stop sometimes, but it's not because my knees hurt, but I'll do it as an act of compassion for my knees. I said, whoa, this guy is like from a different planet. It's like an incredibly moving, commendable planet, but this guy is from a you're acting upon a compassionate feeling for your knees that they shouldn't have to be going through this, like your stretch receptors and your tendons there or something, or setting off fire alarms. This is this sort of detached around for compassion that like seemed like beyond unlikely and amazing in this context. And that was worth the entire trip, hearing this guy just say this one thing. But that's some sort of measure of it. Empathy is very good, but not if it doesn't lead you past that and you just feel self-congratulatory, or not if all it does is produce so much distress in you that you got to flee from it.
Dr. Sapolsky, we are out of time for your fireside chat, but this has been a wonderful time talking with you. I know it was a very quick fireside chat, but we really appreciate your insights and look forward to, look forward to your forthcoming works, especially your new book, Determined, which came out in October of 2023. So thank you for joining us today, Dr. Sapolsky.
Well, thanks. Thanks for having me on. And good luck to all of you folks who are in the trenches, as opposed to us who hypothesize about psychiatric pain, that you're actually doing something about it. So I salute you all. So good. Thank you.
Thank you. All right, just want to guide everyone to the 9-Day Crisis Jam learning community. If you'd like to rewatch the fireside chat with Dr. Sapolsky, a video of this episode will be posted here, along with any slides and materials that are also shared during this episode. And here is an example. I think the last session we met was 9-day polling. So we have a number of unique speakers that have been on the Crisis Jam to this point. I think we're either at or very close to 400 and over 150 plus episodes. If you have an idea for some topics to be featured on the Crisis Jam, please feel free to reach out and suggest ideas and speakers so those could be featured as well. And a link is in the chat if you're interested. Now I'd like to call your attention to some new resources. This is from the New York Times, looking at 10 ways to support your mental health in 2024, and we have more to share. This is a resource from Optum. So if Sarah Blacka is on the call, if you don't mind unmuting and saying a few words about this resource, that would be fantastic.
Yeah. Hey, y'all. Good morning. What Chris has got on the screen is a national database of all the mobile crisis providers throughout the country. So this is something that Optum created as a way for us to support our members when they happen to call us if we found that they were in a crisis situation. We needed kind of an easy button to figure out how to get a hold of the specific mobile crisis team in their area, since we serve people across the whole country. So the resources that are listed here are mobile crisis providers that are separate from the 911 system. We don't have those included that are co-responders that are initiated out of 911. And we also have it limited to mobile crisis teams that do in-community response and not those that meet individuals like, say, at an emergency room or a hospital or something like that. So we try to maintain a pretty comprehensive list. It took us quite a bit of time to create this list, and we wanted to make it publicly available because it was kind of hard to find in some areas, and we didn't want it to be a challenge for other people who may need this. So I can put the link in the chat for this, but folks should be able to pull it up for whatever area you're in. I know I'm speaking to a lot of crisis providers in this room. I will tell you that twice a year we go through and we contact each provider and we validate the information that we have. I wish we could do it more often because I know that these things can change very quickly. So if you don't mind doing me a favor and checking out your state or your resources that you're knowledgeable about to validate if everything looks right. If not, I would love to get that information and update it so that we can make sure that this is as valuable as possible for everybody that we're serving. So I'll put my email address and the website in the chat for folks to contact me if they need to. Thanks.
Thank you so much, Sarah. And I also wanted to call everyone's attention to the Leadership Exchange 2024. I believe registration is now open, and that's going from June 24th to 28th. And then if we can go to the next slide, this leads into another event, I believe the third Summit for Crisis Now, which will happen in Amsterdam from June 29th to 30th. More information is coming related to registration and other details. We also wanted to call your attention to this resource from Open Minds and Monica Oss. So I believe that they have been tracking just a wealth of funding opportunities across various categories. And what they discovered is that the largest category of funding was focused on crisis-specific initiatives. So if you'd like to read more about this, here's a resource that you can access. I believe either a link is in the chat or will be on the learning community. All right, now on to the hot seat. We actually don't have, unless we have a quick volunteer, if anyone would like to go, we're actually going to lean on the audience today for today's hot seats. So if we could queue up the question, we can get this moving. So the 10 faces of innovation describe the third approach as the cross-pollinator. And the key is leveraging solutions from other disciplines and hiring or acquiring diverse perspectives. So here is the question. Cross-pollinators was the defining characteristics of these amazing innovators, but who among these four choices does not belong? Let's go ahead and put in your answer as you're able. Okay, how we doing? Aha, all right, 32%, Orville and Wilbur Wright. The answer actually, if we could transition, is, believe it or not, it's Jane Goodall, who is a world-renowned primatologist, especially in studying chimpanzees in particular. But this is looking at crossing disciplines. Jane Goodall's work is definitely, and she took an innovative approach, but doesn't align with the cross-pollinator definition. So really encourage you to check out the book that was referenced. And David, I don't know if you have a link to that book or just if you put the title in the chat, where it discusses the different types of innovation and how Jane Goodall's approach definitely is an approach, but focuses specifically on aspects of anthropology that is different from these other innovators. Okay, moving on. Now let's turn the time over to James Wright from SAMHSA for a SAMHSA update. James?
Hey, thanks, Chris, and good morning or afternoon, everyone. Just a couple quick things from SAMHSA today. If you have not gone to the 988 Partner Toolkit on SAMHSA's website, I do encourage you to do so, especially the resource section. Can y'all not hear me?
Your volume's a little light, James. I can make it out, but it looks like others may not be able to.
All right, I'm going to get really close to this and speak up very loudly. Is this better? Not much. Okay. Apologies for that. I've got 4 quick updates from SAMHSA's side. Number 1, please do visit the new updated resource search site for 988 on SAMHSA's website. I'm going to put 4 links here in the chat. Maybe I should have spaced those out. The first one is for the samhsa.gov 988 website. That has been modified to allow searchable for resources. There's roughly about 150 resources that have been included in that. I also wanted to highlight today, right after this call, there is a upcoming SAMHSA Crisis System Response Training and Technical Assistance Center webinar on crisis system implementation successes and challenges. You can register if you have the ability to participate. There are 2 more coming up in the near future. One is an upcoming policy academy that is open for applications currently.
We're going to be looking to select 8 to 10 state, territory, and tribe teams to focus on crisis system design. And then finally, we have on January 16th, SAMHSA's Crisis Technical Assistance Center is hosting their monthly Crisis Community Collaboration 3C session, and you can register for that session by following the link and what's being shared on the screen today. So, Chris, back over to you, and thanks for allowing us to do the update.
All right, thanks, James. And now we'll transition over to Najmit for an update from, I believe, Arlene Stevenson.
Hi, good morning, everyone, or afternoon, wherever you are. It's been a while since we've talked about the NASHBIDS model bill. And since many of you are new, I thought it might be nice if I actually explained to you the beginnings of the model bill. And so if I could have the next slide, please. And there we go. And actually the slide after that would be great. We began the model bill in the year 2021, and the purpose of it was to develop a template for the states to give them something basic to use so that they could draft legislation to develop 988 and a crisis services system. The idea was that they would develop something that would be unique to them, that would be useful for them. So the process was we drafted a bill. We worked with our stakeholders. We created, we made edits to it. And then when we finalized it, we sent it out to all the states and to the stakeholders so that it was available to everyone. The next slide, please. In 2021, we started with some basic definitions because every good bill has definitions in it. We coordinated with Vibrant and all the contact centers. And then we began with saying that we needed to authorize the call centers to deploy mobile crisis teams, that the crisis teams will be able to go on site, and that there would be state and federal funds available to make that happen, that they would work with the continuum of crisis services, and that there would be coordination across those services. That would be very important. We wanted there to be consistent messaging for the 988 centers, and that the needs of the at-risk populations would be a priority for this. There would be funding to support the system, and that would be a variety of funding types, preferably. We thought that some of the states might want an oversight body to look at the entire system and to provide some advice. And so we built that into the legislation as well. And that we said that they should definitely make sure that the legislation was consistent with the National Suicide Hotline Designation Act and with any FCC rules. I'm sorry, I'm a little hoarse today. Next slide, please. Then in 2022, as we do every year, we made changes to the bill. We wanted to keep them updated. So in that year, we established that there would be crisis receiving stabilization centers to make sure that it was clear that they are not institutions for mental diseases as in federal statute. And that was so that they would not be limited to 16 beds. We also wanted to improve equity by incorporating cultural and linguistic competency and stating that that was important to happen. We required service linkages to community providers because, of course, you don't want people to be in a system all the time. You want them to get out of the system and to be working in the community on their own. We wanted to improve communication across the response systems. So that was added. And then we put it in there that there should be a trust fund and that should be administered. And that is to protect the funds from being used for other purposes. And that often happens in state legislatures. We also said that the centers and the response personnel should reflect the demographics of the community and that they should be trained to serve at risk populations to optimize the services. and that we suggested what the composition of an advisory body should look like. Next slide, please. And again, in 2023, we worked with our stakeholders again to make changes to the draft bill, and to this time we put emphasis on parity. We wanted to make sure that coverage for mental health and substance abuse benefits were at parity with physical health benefits. We wanted to strengthen crisis response for children, youth, and families because SAMHSA was putting emphasis on it in that year. We required protocols for 988 crisis counselors, for 911 responders, and for law enforcement so that it was done in uniform manner to make it quality. We updated suicide hotline because nobody was using hotline term anymore, and changed it to the 988 suicide and crisis lifeline. We wanted to ensure that the response again was the best it could be, incorporating the language of cultural and linguistic competency. And we required states to pursue sustainable sources of 988 Lifeline Center funding, and that's always an emphasis. And then this year, for 2024, the changes that we incorporated were to clarify that for mobile crisis teams, not only did we have licensed behavioral health professionals, but they could also incorporate certified behavioral health professionals. That in order to assist with collaboration between and among Lifeline centers and community groups, that the state behavioral health authorities should assist with that. That the Lifeline centers must meet the requirements that are set by the Lifeline program and also provide follow-up services. Again, we were thinking about parity provisions, and we wanted to give states some additional power to regulate that. And so we've added that to the bill. And the emphasis this year is being put on the components of a 988 and a 911 collaboration. That is to add coordination, training, and protocols and procedures. And in accordance with that, we added definitions to that 988 and 911 collaboration. So the bill is available, and if you change the slide again, please, you'll see that you can find it on nashbid.org. And if you add in the search engine 988 Transforming Crisis Systems Resources, you'll be able to find the bill. And I wanted to note for you that it is in Word and it's in track changes. And that's so that you can, and that's intentionally, it's not a mistake, so you can easily identify what things are being changed, so you can change your existing statute, and you can easily identify what things we've added to it. So you can always compare. And that at the bottom of the page there is a screenshot of what the front page of the bill looks like, so you can identify it when you've found it. So if you have any questions, you can always call and ask us. Thanks a lot.
Thank you, Arlene, and thanks to NAJBID for this wonderful resource to guide states in knowing how to set up policy and legislation for 988 and the crisis continuum. So very grateful for that partnership and your leadership there. And now moving forward in the presentation, we'll transition over to Christy Malik, who also is with NAJBID, who will be talking with Meryl Cassidy.
Thank you so much, Chris. So I had the pleasure of interviewing Meryl Cassidy. She's the executive director at Response Crisis Center, which is located in Stony Brook, New York. We spoke about the genesis of their follow-up program. And what I found interesting was, there's been a lot of discussion, since the pandemic about the impact of social isolation and loneliness. But while interviewing Meryl, it was interesting to learn that, at her center in the 1980s, they started seeing trends of crisis counselors reporting feelings of loneliness and being socially isolated, and which led to the creation of their follow-up service program called Support Line program. Meryl, thank you so much for joining us. Great to see you again. Can you just share your thoughts and reflections on the role of follow-up support in relation to callers reporting feelings of social isolation and loneliness?
Sure. As you said, it was pretty early on in our center's history We're 52 years old now, so we were founded in 1971. And as all centers, you know, we had a population of people that were familiar to us, our familiar visitors. And the real theme that we identified was, for many of them, they were experiencing social isolation and the need for human connection. That really seemed to be the primary reason for them calling us. So we developed the support line as not only a way of meeting the needs of these folks, but also to try to free up the hotline for people who had more emergent crises. And certainly, you know, we know that the pandemic has really heightened feelings of social isolation for many people. Layering on top of that, you know, more and more reliance on remote ways of communicating with each other, all of that has an impact. So follow-up in the form of fairly structured, relatively brief kind of check-ins can serve many purposes for folks who are looking for this type of connection. Obviously can help people feel more connected and cared for. It can also help them either stay linked with resources or help link them with resources. And it can help us monitor and assess when risk gets elevated and where this population might need more support. You know, life ebbs and flows. It's a bit of a roller coaster and nothing is a steady state. This is a high need population. And in addition to having, you know, all kinds of issues related to social connection and isolation and loneliness, and not really having a solid informal support system, there are usually other struggles going on as well, including struggles with maybe mental health or substance use or both. So, you know, this type of follow-up support can be really, really beneficial.
It was also interesting that you mentioned during the interview about the bidirectional benefits of follow-up calls to both the caller and the 988 contact center staff. Can you elaborate a little bit more about those bidirectional benefits?
I like the way you say that, bidirectional benefits. Another way to frame it would be to just call it a win-win, you know? Yeah, I think there are many benefits for our counselors who are engaged in follow-up work. As crisis counselors, we don't often get to develop ongoing relationships with the people who reach out. So with follow-up, we have that opportunity to really kind of develop an ongoing relationship with our help seekers, find out how they're doing after an initial crisis. Our follow-up programs give our counselors this kind of an opportunity and can give counselors more variety in terms of what they're doing day to day on a shift, which increases job satisfaction and retention. They're also able to develop different sorts of clinical skills. You know, those crisis intervention skills are really important and critical, but these are more ongoing clinical skills, assessment skills, engagement skills, and, you know, problem-solving skills can get more honed and developed with these ongoing relationships. So definitely see it as a win-win, and our counselors really enjoy engaging in this work.
Well, Meryl, it was such a wonderful opportunity that I had to interview you for the Crisis Talk Focus Story. And as you can see in some of the chats, you've definitely, I think, hit some very high level comments about, you know, the value of follow-up services and really helping to support 988 contacts that are feeling socially isolated. So again, thank you. And I'll turn it back over to Chris.
All right, thank you very much, Christy and Meryl for the work that you've done. And great timing, as now we're ready to transition over to Vic Armstrong for Strong Talk. Vic is the Vice President for Health Equity and Engagement at the American Foundation for Suicide Prevention. Vic, take it away.
What's the word? What's the word? Yeah. What's the word? Strong talk, strong talk.
Thank you, Chris. For years, I've heard and used terminology like parity, equity, and integration as it pertains to mental health. We've talked about parity in the sense that we need insurance coverage of treatment for mental health and substance use disorders that is no more restrictive than treatment for illnesses of the body, such as diabetes and cancer. Yet we continue to struggle with being able to hold payers accountable when payment for mental health services are denied or access is unavailable. We've talked about equity as it pertains to race, sexual orientation, and gender identity, access to care in rural communities, and access for individuals living with disabilities. Yet we still lack interventions that are culturally relevant and accessible in communities where people live, work, play, and worship. A lack of access to care in rural communities and a lack of access to resources with the cultural sensitivity and humility to address the needs of our LGBTQ brothers and sisters. We've talked about integration of physical and behavioral health, recognizing that many of the prevalent causes of death and disease are caused by behavioral and environmental factors. And we know that chronic health conditions such as diabetes, substance abuse, asthma, obesity, and cardiovascular disease require behavioral health interventions for best outcomes. Yet, we continue to have siloed treatment for those living with physical challenges, mental health challenges, intellectual and developmental disabilities, or traumatic brain injury. Perhaps part of the solution to building a better system lies in how we talk about system transformation. We often talk of parity, equity, and integration as if they are very different things, leading to siloed conversations with siloed expertise and siloed funding streams, much as we have a siloed care delivery system. The truth of the matter is that regardless what we call it, we need a system that provides a whole person care approach, including physical, mental, spiritual, behavioral, and emotional needs. A system that provides access to care and resources that are culturally relevant, lived experience informed, and accessible in communities where people live, work, play, and pray. On that, we agree. I think we can also agree that the time for talking has long since passed. It is not a question of understanding what we need in the design of a more effective mental health system, but a question of whether or not we have the willingness, the wherewithal, to put our resources and collective action behind creating that system. As with many things, the first step is perhaps not in the learning, but the unlearning. And that is strong talk.
Thank you so much, Vic. And I'm hearing a theme throughout all of the presentations today. It sounds like not only are academic disciplines siloed in terms of understanding the various complex behaviors we're trying to understand, but people are also siloed in their communities and feeling lonely. And really appreciate what Vic mentioned, because it touches on what Robert Sapolsky also said about how empathy, we don't want to just pat ourselves in the back. We want action. We want to move it forward. So thank you, Vic, for that call to action. And also want to echo the next topic, which I think feeds off of what Vic shared. Next week, we'll be focused on, if we could get to that slide. Well, if only we had a drum roll in the background, that'd be perfect. Here we go. So speaking specifically about people with developmental disabilities and mental health concerns, another area that requires more attention, that will be the focus next week, featuring Mary Sowers. But really encourage everyone to try to take this idea of convergence, and not just from an academic perspective, but even in your communities where people are feeling lonely. How do we pull them in? How do we allow them to feel engaged and belonging based on the work that we're doing? I do see in the chat, we are actually doing good on time today. So thank you everyone for the efficiency. If Dr. Richard McKeon is here, invite him to share some reflections if he would like. You're welcome to say no, Richard, but if you'd like the floor, it is yours.
Sure. Can you hear me okay?
Yes.
Okay. Well, I am actually at the airport getting ready to go to the annual conference of the National Association of Emergency Medical Service Physicians, where we're going to be talking about 988 and 911. Also have a chance to visit some innovative programs, and love to be able to share that information at a future point. But once again, today's Crisis Jam was wonderful. And, I think that, our opening speakers, obviously from outside of the crisis field, but I think that the kind of underlying biology around us and them was certainly something I've never thought about, before, but I think has such rich implications for the important part of crisis services involving making a connection with someone. And that obviously has to do with feeling like they're a part of the us world. And, if they're them, the more distance, the more difficult there may be to empathetically connecting, which can play such an important role in the resolution of a crisis, episode. I was also very glad to see, obviously we can't take a, specific position as SAMHSA on it, but I was really interested to hear NASHBID's updating of their model state plan, and looking forward to learning more about that. And then I also loved the presentation around follow-up services and how important they are. And some of you may know this is an issue I've been working on for many years, because the science is some of the strongest in all of suicide prevention regarding the importance of maintaining contact through an episode of crisis. And our systems have not historically been well designed to do that. And it is certainly a major goal for SAMHSA to be able to work to improve that. And there are wonderful examples like the Colorado Rocky Mountain Crisis Partners Emergency Department follow-up programs. There's the work that all of the call centers have done that's been reported on by Maddie Gould, in suicide and life-threatening behavior, which basically says that about 90% felt like follow-up calls helped them not kill themselves by either a lot or a little, and virtually no one had a negative reaction to them. So I was really glad to see that highlighted. So, once again, just a fantastic crisis jam. And Chris, I want to thank you for all of the work that you have been doing in your role at Vibrant in trying to strengthen data and evaluation, which I think is such a critical area for us moving forward.
Really appreciate that, Richard, and also thank you for your impressions of the Crisis Jam. If you're wondering what this slide that's been up this whole time, this is what's coming in 2 weeks following next week's episode of Crisis Jam Debate, the second one with Detective Sabrina Taylor and Dr. Jen Stuber, talking about should crisis care come in a police car. So that is it for today. We'll get to end a little early, and appreciate you attending and hope that you return next time. Thanks, everyone.